saturation and oxygenation will improve. It's same like the high frequency oscillation, it's same like I think these are the two. It will improve your oxygenation. لكن المريض لما تشوف تاخذ 100 مريض hypothetically تحطهم على ARDS ولا تاخذ 100 مريض ARDS كلهم same severity, all males, all مش عارف ايش, all diabetics, نفس الكرايتيريا هنا وهنا. تاخذ 50 تحطهم على نيتريك اوكسايد وتاخذ 50 تحطهمش على نيتريك اوكسايد وتتبعهم تلقى جماعة ال 50 هذول ما يدير oxygen is improving comparing with الثانيين. لكن جي بعد شهر تلقى 15 توفوا من الجروب هذه و15 توفوا من الجروب. ما ضفت شيء. هذا this is the way, in a simple way to explain. هذه واحدة. ثانية النيتريك اوكسايد is expensive. ساعة واحدة على النيتريك اوكسايد $200. يعني كل ساعة $200. فا ARDS عندك قاعد 24 ساعة على الأقل نيتريك اوكسايد. Do the math يعني. This is why people they're not using it anymore. Plus النيتريك اوكسايد ايش المشاكل بتاعه؟ Can affect your kidney, right? So this is one of the problems, right? So لما تحسب البنفيت الكوست والبروبلمز ما
مرات احتمال النيموثوركس بروحها حتى هو
كيف؟
مرات الريسك بتاع النيموثوركس باروتروما
والنيتريك اوكسايد؟
لا هو الميكانيكال فنتيليشن في ذاته. النيتريك اوكسايد ورس من اكثر بعد الموضوع.
اوكي الدكتوره جايه ولا نبدو؟
لا ما اعتقدش انا تصير 8 اشياء.
هي حتى اوراقها راح. شكلها سيء. Okay, so now we'll talk about non-invasive ventilation. You have non-invasive ventilation?
Yes.
Yes, very good. You have it in the emergency room?
Yes.
And you have it in the ICU?
Yes.
And you have it in the CCU?
Yes.
Okay, so everyone, you all used non-invasive before?
Yes.
All right, so I'll ask questions now. All right. We'll skip the objectives for now and we'll go straight to the... So non-invasive means, from the name, just basically pressurizing the air, go to the lung, air under pressure without putting ET tube inside your patient, without endotracheal intubation. You can use in acute and chronic, but mostly now we're talking about acute. We just covered the acute indications. One of the problems with the non-invasive is you need you to pay attention. You just don't put someone in the machine and you walk away. You need to look at a few things to make sure your non-invasive is working. And the things you need to look at is my patient candidate? Is he the right candidate for non-invasive? For example, you don't intubate someone who is pre-arrest, for example. Someone who is not awake. Someone who having a lot of secretions. Someone who is very anxious and he's not aware of what's going on. Someone who's not cooperative. Someone who doesn't listen to you. Say, hey, slow breathing. Someone who's claustrophobic. So you have to pick up the right patient. That's the most important. To ensure success, you have to pick the right patient in anything in life. Right? You have to monitor your patient. Is he comfortable? Is there any leak there? Right? Is he breathing slow? Is the non-invasive is helping him? So you need a frequent visit and frequent talking to the patient and making sure that what you're doing is the right thing. I think we'll go over this in more details. It's the first line of defense now in any hypoxic patient. Every hypoxic patient comes to your ICU or CCU or ER and he's in shortness of breath, especially COPDs. You have to try non-invasive before you intube them. And this is the flow chart of the Society of Critical Care. I'll show it to you. Everyone goes in non-invasive. He fails, you intubate them, but don't just jump to intubation unless, again, patient cannot survive. Yeah. So, selective guidelines. Right. Microsoft error reporting. Come on. So when do we use non-invasive? As I said, you can use it in everyone who is common hypoxic respiratory failure, acute especially, put them on non-invasive. You lose nothing. You can use it on anyone who requires in respiratory distress instead of on top of oxygen therapy. Someone who is dyspneic, tachypneic, using accessory muscles, paradoxical breathing, have a problem with the gas exchange, mostly in COPD, CO2 is up, pH is crashing, right? But the pH should not be less than 7.1. Someone who's severely acidotic, they're a recipe for failure, so probably they need intubation. Respiratory acidosis, not metabolic acidosis. So the most common successful indications for non-invasive is COPD exacerbation, whether asthma, emphysema. They are the people who are commonly studied. There's a lot of studies supporting non-invasive there. The second group of patient people with pulmonary edema. Pulmonary edema, there's the difference between COPD and pulmonary edema is what? COPD, they retain CO2, right? And pulmonary edema, they hardly retain CO2, becoming hypoxic. So to have someone who is retaining CO2, you need BiPAP, very good. And the second part, you need just CPAP. You just need to recruit more alveoli. CPAP is PEEP. It's the same thing, just they're called different ways. So CPAP, if you hear someone saying CPAP, this is the same like PEEP. So these are the two indications. But as I said earlier, used on everyone. Everyone fits the criteria, used on them. Don't be shy. The hypoxic respiratory failure, for example, because of interstitial lung disease or ARDS, it actually is on the guidelines for treatment of ARDS. You can use it. Non-invasive, even in ARDS, not severe ARDS, of course, mild to moderate ARDS. Okay, so remember this statement: a trial is worthwhile in all patients unless they require emergency intubation. And the people who require emergency intubation, it's not going to come across your mind anyway. You will intubate them straight, especially if you're in the ER, right? Someone who's crashing, you're not going to do non-invasive, right? So you put the tube straight, or someone who's paralyzed or sedated or in an heavy. You're right. So but otherwise, try it in everyone. And the more you use, the more experience you have, the more patients you save, and the less problems you have. And the advantage of non-invasive is you avoid all the complications related to the invasive mechanical ventilation. Mostly pneumonias, mostly patient will stay shorter time in the hospital. You will not give him all the sedation you give to intubated patient. You will not be fighting. There will not be a lot of advantages. So this is the people who will do good. Sometimes this machine skips. Here we are. So these are the patients who will do good on non-invasive. Predictors of success. If you have a young patient, why a young patient? Because young patient will understand you, right? You tell them, hey, we're going to put the mask, you breathe slowly, and you feel uncomfortable at the beginning, but later on you get used to it, it will help you to breathe. But you have someone who's 70 or 80, or it would be challenging to just explain this to them, right? So young age will do better, right? Low acuity of illness, not someone with severe ARDS. Probably he needs intubation straight away, just wasting your time if you say I'm going to try non-invasively, right? Someone who's been in the ER for 3, 4, 5 hours, a non-rebreather mask, and you come and say, hey, let's try non-invasive now. It's not going to work for him, right? So, of course, cooperative patient, someone who can understand what you tell them, right? Someone with a CO2 of 120, probably this is not a good idea. You can try it. Again, there's no harm. If your patient is cooperative and understands and you've used the machine before, you can try it, right? But they're saying if your PCO2 more than 92, the chances are less. If your pH is less than 7.2, 7.1, probably it's a little bit, it's not dangerous, but risky. It's called risky. And of course, there is a place where you can put the mask, not someone with a fractured nose or trauma patient or small mandible or whatever, right? So we have someone who yeah. Okay, so these are the people who will do good on non-invasive, right? It's a common sense, right? You didn't have to. These are the people you should not use non-invasive. Someone who had a cardiac arrest. I don't know why the title is not shown up. Someone who is hemodynamically unstable. Someone 2, 3 pressors, the doses are going up there. Clearly there's a blood pressure there. Non-invasive is not, but you need to have a proper controlled oxygenation in this patient. And the way to do it, you didn't have room for 2 hours or 3 hours or 4 hours. We're seeing if your non-invasive is going to work or not. So it's better to intubate them straight away, especially septic patient. Someone you think, hey, this guy will be on mechanical ventilation or he needs some help for 5 days, right? So there's no point, because the average time you use non-invasive is how long? How long you keep your patient non-invasive? 48 hours, right? So I usually keep them for 48 hours. If they still need a lot of support there, I intubate them, or high flow nasal cannula, as we will see later on. But the longer the time, the more trouble you will have non-invasive, right? The patient will start hating you actually with this, especially if you're using high pressure. Patient is not listening to you, incooperative, claustrophobic, doesn't like this mask, right? So actually they will fail straight away. We said this is the same rule like the cardiac arrest, someone who is not with you consciously, someone who doesn't have a room to fit the mask on them. But there's airway obstruction. You can use someone with angioedema, for example. Someone has thyroid surgery and everything is swollen here and you give them a mask. Don't do that. They need intubation. Okay. The only exception for low GCS is, this is based on small studies, someone with encephalopathy secondary to CO2 narcosis, retention, because it's a reversible cause. Once you drop the CO2, they will wake up, and usually you get a response within 2 hours. So it's worth trying in these people. So someone who has a CO2 narcosis, most of these patients, I would say 99% of these patients, they are COPD excessive patient, right? And you know for a fact that the COPD, they're a good responder. So give them a try. Don't say GCS is low, I'll intubate them. Give them a chance, right?
Yes.
Don't be scared. All right, so these are the different masks we use. I don't know which mask you have.
Mostly the P1.
A only. B.
A,
بي ميل للبي الميل للبي ايه مرة يكون متوفى.
Okay. You can try any mask you have and see if your patient is comfortable with it. If so, you have, let's assume you have all the six of them, all kind of masks, including the helmet. Just listen to each other, guys. Just listen. I tried like the A and patient is not happy. You can try a different mask. Maybe the nasal one would be You'll be comfortable with it. Maybe the helmet, that one now, it's more popular. The one the patient wears and you can talk and there's no pressure on their face and they can eat and drink and do things. So see what mask fits your patient or he's happy with.
E.
What's that?
E.
E?
Better for patient.
Where's
صح
the
ده في حتى الفشل deformity مش معنى.
E? Yeah, face mask. Some people prefer face mask. Everyone have his own
لكن على
السي
الاي
كويسة.
comfort.
شيء على الربي بس.
Okay, let's move on. This is a real patient and the same thing. All right, this just tells you the difference between nasal and oropharynx. Doesn't matter. Again, whatever your patient prefers and whatever works for you. Okay, or you combine both. Helmet, we're gonna skip it. How to initiate the non-invasive? Let's see how you do that. Who you said everyone, all of you have the. And you use non-invasive. You're in the ER?
Yeah.
I come to you with the COPD exacerbation. What's your plan for me?
So
How
first, I'm going to see my patient.
Okay, you saw me, you said, okay, I'm hypoxic, but CO2 is in the 80s, and you want to start me non-invasive. How you do that?
There's three things. His EGG, his BH is
As I said, there is a clear indications for respiratory support. Either you intubate or you do COPD in the patient. You want to try non-invasive.
Explain
أول شيء حدثتك عليه.
explain.
How you set it up. How you do it.
non-invasive مو
Non-invasive. How you do it. Okay, anyone else?
explain البيشنت.
Explain. Okay, very good.
بعدين الماشين
بريبير setting
نبدل
What setting you want to start?
according to مثلا لو انه هو هيبوكسيك نحط سباب مثلا.
He's hypoxic. His PaO2 is 51, and his CO2 is 85.
سباب بايباب مثلا.
You want to do BiPAP? Okay.
سيتنج عندي الليفل عندي البيب والبريشر
So
سبورت
let me help you. IPAP and EPAP. IPAP
I
is
have
the
4 to 5, right?
خليه يجاوب كما أعرفش نسألك. IPAP is the air you blow in his lungs with each breath, and the EPAP is we said the peak, right? So how much EPAP and how much IPAP?
ستارت لو مثلا الإيباب بدي 5
Okay.
والآيباب 15.
15.
Yes.
What should be the difference between EPAP and IPAP to have a gas exchange?
more than
Why we give an IPAP anyway? When someone else. Why we give an IPAP, دكتور؟ انت ما اشتغلتيش اي سي. هو اشتغل لا مين اشتغل؟ الكل على الميلز. Let's go for the females. مين اللي اشتغل اي سي يو؟ ما فيش حد. What's the difference? How much difference you should have? 7, minimum 7, right? To have a good tidal volume gas exchange, wash out the CO2, you have to have 7. The bigger the number, you start at 7, right? And then the follow-up blood gases will tell you my CO2 start coming down, so I'm happy, keep it there. Because remember, the higher the pressure, the more discomfort, the more chance of failure, right? المريض يبقى الاير blown and pressure in his face, and he's especially if he's not synchronized with the machine, they will fail. ساعة ولا نص ساعة ويقول لك دكتور معلش I can't stand it anymore, right? So use the minimum pressure. So I would start probably at 12, 5 and 12, and see how the blood gas. What's the best predictor of success? You started someone on this set at 12 and 5. When you say you come back an hour later and you look at your patient and say, hey, he's doing good, or no, he's not doing good, without seeing the blood gas. Perfect respiratory rate. He come in breathing 35, the kidney, and now he's calm, rate is slowing down. That's the best predictor, right? If I come back an hour later and his rate is still 35, probably, yeah, we have a problem here. Don't take him off the machine and tubate him, but find out why. Maybe the mask is not good, maybe there's leak there, maybe he's in pain, maybe he's not comfortable in the bed because the bed is not comfortable. There's something there. ما عندش مخدة ولا مش عارف إيش. Make sure that you're not missing anything, something silly there. You did everything perfect and he's still tachypnic, and you do the gases and the CO2 start going up or the oxygen is not improving. That means probably within 2 hours you should be able to make a decision. Okay? So your patient respiratory rate came 35, now it's 30, right? And you did a blood gas in him, and remember it was 51, now it's 55, and the CO2 came in with 81, CO2 now is 80.
Not that important.
You improve the oxygenation, but the
the CO2.
ventilation. So what would you do?
I will increase I will increase
iPad.
I to E ratio.
IBAP.
IPAC.
Yes, increase the IBAP.
IPAC. You increase the pressure. You increase the gap between the two.
Start the ventilation up.
So more air will come in and out and more ventilation. So the what's the minute ventilation? You know?
Respiratory rate, tidal volume.
Right. The ventilation is controlled by two things: how fast we breathe and how much air we go on. We take in, right? You breathe fast, you wash more CO2. You get more air in and out. You wash more CO2. Right? So this is the same principle. You can, huh? The iPad is
Pressure support.
the pressure support or the air you blow. There's two pressures in the BiPAP, right? Two pressures. Right? Feel pressure which sits on the lung all the time. It's called BPAP. My lungs and say is like this, and I'll breathe on top of that. P, CPAP, EPAP, whatever you want to call it. وفي pressure which the machine will give with each breath. This is the IPAP, inspiratory pressure. So this is what I mean. It's the same thing. It's the same thing. It's the same thing. Guys, if everyone talks to each other, we lose it. So let's talk one at a time. تفضل.
النقطة الدكتور هي بس ممكن تنبال عليهم أن الأجهزة اللي في الآي سي يو هي تستخدم فيه هاي الباب، أما الأجهزة اللي في الآر هيستخدموا بريشر سبورت وبيت بس، يعني هي ممكن تكون راحت الفكرة بيناتهم.
Well, now we're talking about the principle here. As we will see later on machines, the way I describe it is like لما تشتري تليفون جديد تقضي وقت عشان تتعلم كيف شغال التليفون هذا صح؟ It's the same with the ventilator. There's like maybe 10 in the market there.
يفيدك شوي بحاجة؟
This is the screen you see on the ventilator.
هذا
هاملتون.
Hey, you can show it to him if you want.
يقدروا ينزلوها الكاس.
نعم. Which part is not clear to you?
مش نفهم الفكره خاصه لما يزيد الايباب يزيد البريشر على اللنج ولا؟
Yes.
هذا الفكره المفروض جروب الاكسجينيشن ولا مش CO2 وش اوت.
Okay, and just do it yourself now. If you breathe like this, or you breathe
لا الثاني هذه
ما-
بطلع واحد.
more CO2, you wash more CO2. Very good, it's the same principle. You're given a pressure, and the pressure will give you what? Volume,
Yes.
right? You have two types of mechanical ventilation. You have a pressure control, then you have a volume control, right? In the volume, I guarantee my patient you will have 500 volume, 400, whatever I decide, right? In the pressure, I cannot guarantee the volume, right? I just give him, I want the air to go in his lungs in fraction of a second, 0.4 seconds, for example. I want the lung pressure to hit like 30. That's what you do, right? Right? How you ventilate your patient? You give them volume with limited pressure. You control the pressure, but you didn't control the volume. It's the same principle. You give them pressure, he tried to breathe. There's two ways of doing it here. But patients try, like, as soon as he tried to suck some air, the machine, there is a sensor there. There's two sensors in the machine. One is for a pressure, negative pressure, and one for the flow. The machine will say, hey, he's trying to breathe. Let's help him. We give the air under pressure from, for example, 12. right? And you can give it for a certain time, flow 75%. You don't have to worry about this. But if I give it air under pressure, I'm giving volume. So I increase the tidal volume. If I go high under pressure, the volume will go higher, right? If I give it under small pressure, the volume will go small. So volume in, volume out means
Ventilation.
ventilation, CO2 wash out. Is that clear? Bingo. رجل واحدة ولا مبروك على رجل واحدة. Okay. So what would you do? خلي someone else يحكي. What would you do? So again, oxygenation improved, but ventilation did not improve. We said we will go up on the. I just explained it to you, man. High PAP, right? So you go from 12, you go to 15, and again, high in this machine, try to go slow because same principle like the PEEP. You want to see what's the best effect with the minimum pressure. You can jump to 20, 25, and your patient will become uncomfortable, pressure high, air blown in his face, and he will just take it off himself, right? Because you try to be nice with your patient, try to save them the intubation, right? So go up to 15, 18, 20, right? Go slowly based on your CO2, right? My CO2 is, even if there is like 2, 3, 4 points drop in your CO2, I'm good, right? If it's going up, then you have to be more aggressive, of course. So you have to judge it clinically. Look at your patient, see how he's doing. He understand. Oh, I'm gonna go up higher in the pressure. You feel more pressure in your face. Just bear with us. That will save you the intubation. You just keep talking to them, and this is the most important point in success if you're putting someone in non-invasive. If you just throw it on and you walk away, حترجع بعد 5 دقائق المريض شال الماسك and he's in trouble. So you have to keep talking to them, right? You or the nurse or لو في حد relative جنب المريض تفهم ايش يصير وهو calm him down. So this is the suggested protocol. I think we covered everything there.
هناك عادة الدكتور ندير فيها اي تو اي ريشيو يزيدوا في الاكسبيريتوري تايم. ايباد تو سمعت الماشين كيما نشيل واحد نخلي 1 إلى 3 اكسبيريتوري تايم 1 اكسبيريتوري ريشيو يعني خلي 3 4
خليه في 3 4 with the same pressure.
هذه ما نعرفهاش بكره بصراحه.
يعني you keep the same pressure and you go up on the ratio.
صح؟ بيب قاعده 5 يعني.
لا البيب ما غيرناش شيء.
ما ليش علاقه بها.
البيب خليناه 5 لانه هو oxygenation improved. لكن the pressure we give by means 2 in out. So the one in is the beep which is the I. انت انسى الاسامي اللي عقدناك بها. في بيب وفي دراجن بريشر صح؟ في بريشر يدخل للمريض مع كل ما يتنفس الجهاز يساعده صح؟ فانت لو تزيد الضغط هدايا هو you can increase the ratio لو المريض فاهم والمريض ساعدك في الموضوع لانك انت when you increase the ratio انت حاول انك انت تتنفس بالطريقه اللي تحكي عليها هذه 4 to 1. مش هتعجبه المريض الريت اوف فيلر يزيد انك انت you fail with the machine will be higher لانك انت reversed ratio or increasing the ratio بالطريقه اللي تحكي عليها. This is one. The other one is if you increase the ratio تخليه 4 to 1 هتعمل ايش الاكسبيريشن؟
1 to 4
short
4 يحط فيه
هو اللي فيه 1 to 4 1 to 3
يديروا prolongation للاكسبيراتوري فيس.
ويقصد 1 to 4.
Okay, this is if you have CO2 retention that helps. But if you have oxygenation problem,
لا بزيد الاكسبيريتوري تايم
worse.
بتزيد inspiratory time. If you have both
الريشيو
هو ده اللي نحكوا فيه البايب انت مش فاهم
انا مشكلتي في الاي باب هذه بس كشنيه وشنو
والله ما عادش نعرف كيف نشرحها لك دكتور لكن بعد البتاع بعد المحاضره هذه ماشي هو you can do this if you have a single problem if you have oxygenation problem or you have ventilation problem especially if you have ventilation problem then oxygenation you're going to use a CPAP so you're not going to use the BiPAP هذه واحده unless the patient is tachypnic sometimes you help them a little bit with BiPAP to decrease the work for breathing لكن what I want to say now the right way is to go up in the pressure. If you reach a pressure, say وصلت 15 pressure or 18 or 20, and the patient tell you I'm not comfortable with this pressure anymore, right? Or you didn't have the right mask. يعني حسيت ان المريض خلاص ده منزعج يعني, then you can work on the other, you can change the ratio, بتغير الثاني هذا. لكن انك انت تعطيه pressure of 12 and 5 وبعد كده you reverse the ratio for someone who is hypoxic, hypercapnic, probably it will be difficult يعني, difficult to, the gases will be a mess and match, تبدأ الأمور تعقد عندك يعني. You have to go stepwise زي ما حكوا لك. Yeah? Any other question? No. Doctora, any question? So, you're good. Okay. So here, just pay attention to 11 here.
Monitor.
2 hours. 2 hours. This is the magic number. Plus or minus. It's not written in stone. Yeah.
1 hour.
لكن خلال ساعتين you will be able to judge if your patient will respond to the non-invasive or not. Okay. Again, I'm missing how to monitor this patient. And they say in here in the first 8 hours, again, this is society recommendations. You look at them, you talk to them, you reassure them, look at their heart rate, respiratory rate, hemodynamics, saturation, how things are. Go in the right direction, everyone is happy. There's a problem there, you have to deal with it. You should see some improvement on the blood gas within a couple of hours, right? If you do a couple of hours and your patient is not doing well, you need to intubate them. Don't worry. Don't say, okay, I'll give it another 2 hours, 4 hours. They will fail.